Perfect.
I cannot see you. I don't know if others or
I
can
can
folk
see Owen.
okay, that's fine. As long as everybody else can see. It's great. There he is.
Okay. We have Sarah Lindbergh, Matt, and Flora. Yes, great. Okay. All right. Well, it's 8 a.m. Cassidy, are you all set?
I'm ready, Chair Foster. Thank you.
Great. Okay, great. Well, I'll call to order the Green Mountain Care Board's hearing of August 14th, 2023. Today we have Grace Cottage and Northwestern in the morning. And then this afternoon we will have Rutland. And so I think Matt Sutter will be doing the Grace Cottage and Northwestern walkthrough. And then Director Sarah Lindbergh will be doing Rutland this afternoon. So I'll turn it over to Russ McCracken to swear in the witnesses, and then Mr. Sutter can take it over from there.
Thank you, Chair Foster. For the Grace Cottage team, who will be presenting and answering questions today?
Doug's on mute, so I'll speak for him. Doug DeVillo, CEO, and myself, Stephen Brown, CFO.
Great. If you could both raise your right hands, I'll swear you in. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
All right, thanks very much. And I believe the floor is yours.
Great. Well, good morning, and thank you for having us today. We're very pleased to be able to meet with you to present our budget and answer questions about it. We put a lot of work into refining our budget for 2024. Although I will say, we do continuous budget development all year long at Grace Cottage. We review the budget every month and make adjustments as we go in terms of our operating strategies and our fiscal determination. So, doing the budget every year is a pretty simple process for us because the 2024 budget is really just a continuation of our 2023 activity and performance, which we think has been quite exemplary, given the challenges and the struggles and the difficulties in running healthcare organizations these days. So hopefully we'll be able to answer your questions and make it very clear what we want to do in 2024 as far as our financial strategies are concerned. For those who don't know Grace Cottage all that well, there may be a couple of you, 2 or 3 of you. I just want to say a couple things about the organization. We're an independent, not-for-profit healthcare facility. We're located in rural southeastern Vermont, about 19 miles north of Brattleboro. Our multi-facility campus of about 10.5 acres includes a 19-bed critical access hospital where we provide skilled rehabilitation, we provide acute care, we provide palliative care, and of course 24/7 emergency care. In fact, we just recently completed a renovation of our ED to add an additional 17 by 42 foot extension to better serve our community and to better increase our productivity and our accessibility to patients. And we're very proud of that renovation. We also have a full service laboratory here in the hospital. We have a diagnostic imaging suite, which includes a recently updated CT scanner. One of the things we're really proud of here at Grace Cottage is our rural health clinic. It's kind of the crown jewel of our organization, where 13 healthcare providers provide over 31,000 patient visits, both primary and mental health visits every year within the clinic. So it's quite a large operating unit for Grace Cottage. We also have a very rapidly growing outpatient rehabilitation department where we provide physical and occupational therapy. We have a full service pharmacy, retail pharmacy located across the street from the hospital at Messenger Valley Pharmacy. And we also have a community wellness center where we all offer wellness programs for the local and surrounding communities. As I said, we're dedicated to providing primary care. We don't do anything in the way of invasive procedures here. We don't have an operating room. We really focus on emergency medicine, acute and skilled and rehabilitation services within our facility, and obviously our large rural health clinic where we provide tens of thousands of visits to patients, where we focus on wellness and keeping people out of the hospital and keeping people on a track to taking care of themselves. And that's really what we're known for and what we're quite proud of. And as you'll see in the budget, when you review the numbers, you'll see that we've had a pretty substantial growth in our volumes year over year. And that's really helped us to weather some of the challenges that a lot of hospitals are facing on the tail end of this terrible pandemic we've had to deal with. So with those opening comments, I'll ask Steven if he wants to add anything to any of the things that I've had to say. And if not, we'll answer questions.
This is great.
No, I think you gave a good quick overview, and happy to try and answer any questions you might have about what we submitted that we haven't already responded to.
Okay. See ya. Thank you very much for lunch.
Someone's unmuted. I'm getting a little feedback there.
I believe I muted that. Are you able
Thank
to
you.
hear me?
Sorry. Thank you. Yes, thank you.
No worries. All right. So in our efforts at continuous improvement, we just wanted to make sure before we dive in that we sorry, I don't know why. Okay, am I not the one presenting? Okay, I'll try and share another way. Sorry, but we wanted to just make sure that our conversation today is focused. So you can see that the topics in the Grace Cottage budget that we wanted to make sure to hit were just making sure we understood some of the variation in the cost inflation assumptions, understanding the amount of the charge increase likely to or expected to be realized from commercial insurers, making sure we're all clear on that. Just covering a question that was already asked about the Medicaid price increases and covering some ACO participation, some of the referral and follow-up responses, as well as the lag and visit information. So with that, I'm going to turn it over to Matt Sutter to go over the budget. So I will be driving for him. Go ahead, Matt.
Thanks, Sarah. Can you all hear me all right? Great.
Yes.
Okay, so looking at the overview, if we just restrict this to critical access hospitals and kind of get a better feel for Grace Cottage's position here, consider NPR growth was just over 16%, so above the benchmark, but below the growth in operating expenses of about 14%. Notably, however, if you see those, their charge master and commercial price increases, they're at 4% and 2% respectively. So growing more for utilization, it suggests. If we go to the FY24 tab. Thanks, it was a little small. Sorry. So going down the list, as we just mentioned, NPR and operating expenses exceeded the benchmark. The NPR exceeded the benchmark. We didn't have a explicit benchmark for operating expenses. So, but for labor, it's grown within the benchmark. And if we switch real quick to the labor tab, I think we can see that it's grown. And then, yeah, thank you. You can see it's kind of kept in line with the ECI benchmark starting by 17. And then going back to the FY24 budget. I wanted to pause real quick and make sure. I didn't think we had any questions about their labor estimates or utilization on the staff level, but I wanted to pause real quick, make sure there's no questions from the board.
Matt, I had one on commercial price. I'll wait if that's a different.
Okay, yeah, I think.
Just on the overview, it said 2%, and here it's 9.3. Is that just because the time period's different here than in the overview page?
That's correct.
So this is for 24 over 23 is 9.3, but then on the overview, it's 22 actual to 24 budget. Oh no, this is 23.
Yeah, and I'd say that I don't want to speak for Mr. Brown, but I'd say that exhibit was a real bear, especially for some of the smaller hospitals. So this 9.3 might be not the most relevant indicator for how they.
Is it also including volume increase in that period, not just that we increased? I think the 2% is we got an additional 2% reimbursement on anything that we billed to commercial versus the total commercial that we got went up by 9.3 based on the fact that the volumes are up.
Yeah, this was designed to try to, yeah, it was designed to try to just get the effective price over the 2 years in that exhibit 10. And it's not a trivial thing to pull out price and utilization, and often.
No.
Yeah.
I can assure you our commercial increases have not gone up any part of 9.3%.
What would you say it has gone up from 22
well,
to 24?
It varies certainly by payer, but the majority of our commercial payments are based on fee schedules. Everything in the rural health clinic is based on fee schedules defined by the commercial insurers. And, at best, they go up a minimal inflation factor each year. They set those. We don't have any control over those. It's not really relevant even what we bill the commercial insurers for anything that's paid on a fee schedule. So for anything in the rural health clinic, the majority of our, our outpatient work for commercial is also paid on fee schedule. For instance, everything Blue Cross pays us as one of our biggest payers for both diagnostic imaging and lab is all a fee schedule that they determine. Again, it's increased annually based on a very minimal inflation factor. So I think the 2% is probably an average overall of what we got additionally for any particular item that we build 1 year over the next.
Thank you very much.
I do have a question about utilization if we're ready for it.
Sure.
So I did notice in your submission that, and as you just spoke to, your utilization is based on current levels of volume for the first 7 months of fiscal year 23. Could you give us a little bit of color commentary on what areas that utilization seems to be most prominent? Is it across the board, mostly in the rural health clinic?
The biggest area is in the emergency department. I mean, mind you, our average number of encounters in the emergency department was generally in the single digits, so we're not talking huge volume, But thus far this year, the emergency department has been up like 40+% over budgeted number of encounters, which, only gets you from, say, 8 to 12 a day. But the outpatient rehab is physical therapy and occupational therapy is way over budget and continues to be. She's got a stack of referrals for outpatient work. People are pre-booking for post-surgery, through like visits in December. And it's just, I don't know if it's people are finally getting work done that they put off throughout the pandemic, or more and more people are just needing to get work done, probably based on the health of the general population. That's part of it. But they've been extremely busy, just, people walking in the door. So the rural health clinic has been a little busier. The providers are seeing a few more patients, but it's mostly those two areas. And then, of course, as the emergency department's busier, some of the diagnostic imaging, particularly CT, is also over budget on the outpatient side, mostly related to emergency department visits as well as some lab.
Thank
We
you.
haven't changed any service lines. It's just more people coming in to use those.
Thank you.
Just a quick follow-up question about, I'm wondering if with the increases in volume and ED visits, how many beds are you currently staffing? I know you have a 19-bed critical access hospital, but how many beds are you currently
19
staffing?
beds set up, or licensed for and set up or available. We generally have a staffing level for an average daily census of 12 to 13, and that's pretty much where we've been running most times. I think our current average for the year is, for total acute and swing, is like 10.8 or something like that. But, that's usually fluctuating between an average or a daily census of 12 to 13 down to 8 or 9, going up and down depending on when the admissions come and go. But on average, there's around 10 to 11 people in the building at any one time.
Great, thank you.
If there are no other questions about utilization, I think we can move to pharmaceutical costs and cost inflation.
Okay.
I was just wondering, so your pharmaceutical expenses increased about in line with what we've seen across other hospitals, and the cost inflation also met the benchmark. I was just wondering if you could maybe provide more detail for context for what you guys are seeing for cost inflation across different services or different supplies, pharmaceuticals. Just kind of speak to what you guys are seeing this year.
Our pharmaceutical cost, as you'll see, excuse me, compared with other facilities, is a relatively small number. In great part because we do not do any surgeries or cancer type drug treatments. So the majority of what we have from a pharmaceutical standpoint are, in general, relatively lower cost items and not huge volumes. It's, mostly small amounts for outpatient ER visits and whatever our inpatients, which are primarily swing beds. So by the time they get to our facility, they're not usually on, some of the drugs necessarily that an high level acute patient would be getting. And it stays pretty consistent, but as with anything else, some drugs go up a lot, some go up a little bit. It's really hard predicting inflation. Looking at the numbers that we quoted in our narrative overall for various areas, those are our best guess as trying to base it on what it has been over the past year, what you think it might be. A few of the things, you might have predicted growths coming from our group purchasing things saying we might see this going up. But sometimes, I'll sit here and look at accounts payable bills and see that, a food item went up 10% from one week to the next. It's just still fluctuates so much on things that you have no control over.
Sal, were there any other staff questions on the cost inflation?
I think I'm good. Flora, anything from you?
No, thank you.
Or were there any board questions on pharmaceutical expenses or cost inflation?
Any questions from the healthcare advocate on any of the topics we've covered so far?
Forgive me, I completely forgot to ask that.
That's okay. No, good morning. This is Sam from the Healthcare Advocate. Nothing from us on this. Thank you.
Matt, would you like to walk through this, or would you prefer I do it?
I
know
think
that,
you can probably, I can do it, but it will be it will waste a little bit of
No
people's
worries.
time. So, thank you.
So we know cost reports are measuring one thing, and what stands out to me is even among critical access hospitals, Grace Cottage is extremely small. So right at that bottom end of the distribution here. So as a reminder, this mark in the middle would be the median. So half of the values are below it and half of the values are above it, down to the 25th percentile. So, and up to the 75th percentile. So we have our middle 50% of the data, and then we have 1.5 times the distance in that box plot.
Right.
And we see that Grace Cottage is very, very tiny. And
I
low
not to
acuity.
interrupt you, Sarah, but just, comparing us with the other 7 critical access hospitals, as you well know, is the best comparison you can have. But in reality, we don't even compare with them because we do not do 2 things that make up the majority of the business in both, which is operating room, surgical suites, and delivering babies, which are both, high volume and cost services that we don't have. So that's what makes us stand out so much from everybody else.
Right. Yeah, totally. And you see that in the, very relatively low acuity, so just over 1.
Yep.
And then we see, so this is kind of the inverse of that small issue where the ratio of admin to clinical is quite high. And I believe that would be due to relative to these other ones at 36%. Right. We certainly see those numbers for some other hospitals for different reasons. So I'm assuming this has to do with some fixed costs, but curious how you interpret that.
Exactly. I mean, we're spreading, say, human resources director over a smaller number of employees. Everybody has one human resources director. When you're dividing it by 19, the employees for a 19-bed hospital versus the employees for a 25-bed hospital, and pretty much that applies to a lot of positions throughout the facility, a lot of fixed costs in it, particularly a small facility like this.
Yeah, and I was just curious, back of the envelope of your, operating expenses, how many of those are related to the fixed costs associated with labor?
I mean, and again, it's also hard, when you look at a lot of those kind of positions where they fall under, say, administrative costs, but a lot of what they do on a day-to-day basis is job responsibilities that might otherwise being on somebody else's budget be not showing up in administrative costs because you've got a whole separate position doing that and it's classified as something different. So that also makes a huge difference here. Certainly not that we're paying all those people far more than they're all getting at any of the other 8 facilities or 7 facilities.
Right. And then I'm just, I don't even think so cash available to operations, obviously not surprising to see that on the smaller side as well. And then for EBITDA, per adjusted discharge, we see, I think that you were just here near there we are. Have to keep working on that. So a little bit profitable, certainly still 22 is nowhere near where anyone expected to be. And as far as the cost per adjusted discharge, we've got, I think you're right in this clump at 14,000. So again, and thanks to those who have given this some diligence, more accurately saying that this is the average cost per Medicare discharge, which is adjusted for that acuity. So we see kind of most of our see some bunching there for the Vermont hospitals. So any board or HCA questions related to the cost report results here?
Nothing from us, Sarah. We wanted to ask about the admin and general salary ratio, but you asked that, so thank you.
Sure thing.
Hey, Sarah,
and then
real quick on the admin. Which hospitals of these others do you think are most comparable to Grace Cottage in size? And where are they on admin?
So the closest one for size would be Mount Scottney. I'm sorry, I won't steal your thunder.
No, I was just, I think from an actual bed size, we are the only one, we are 19. Everybody else is 25, correct? I'm pretty sure. But again, everybody else, when you're taking that as a percentage of, say, total operating expenses, we don't have the operating expenses such as running surgical suites and things that are a huge additional amount. What's the next closest overall expense level compared to us is probably significantly higher.
Yeah, and I think the other thing I always think about with any percentage is low numbers, low denominators just add a lot of volatility to this. So yeah, so I think that's another important point. And then for cost coverage, so again, this is repricing claims based on the Medicare allowable cost. And looking at how that cost coverage is over time. So we see some, relative improvements in the commercial cost coverage for outpatient, and it looks like a bump up in inpatient after quite a bit of stagnation, but still not up to 100%. Medicare, fixed at that kind of cost-based reimbursement.
Right.
And see quite low relative cost coverage for Medicaid outpatient, a little relative improvement that seems to have been lost over time for Medicaid. And we see that actually a relatively lower cost overall in delivering those services for commercial recipients of care with cost coverage about 148% of that Medicare allowable cost, but seeing again only half of the cost coverage for Medicaid. So almost kind of a push, I'd say, between those two buckets. And any questions on this set of data before we? Okay. And so this one, remember, we've lumped things together for several years here. Oops. And it can be difficult to actually see these guys pop. So apologies as I hunt around a little bit, but I think that might be, Oh, you're too small to be in this data set. Of course, that's why there's no grades to highlight. So, so there needs to be a certain number of discharges to be included in the RAND study. And even if you lump 3 years together, they don't qualify for a public data file. So just always helpful to remind ourselves how relatively small Grace Cottage is compared to other hospitals. So I think that is the data portion. So I'll turn it back over to Matt to kind of help facilitate any other discussion.
Great, thanks, Sal. We had a question about ACO participation. I was wondering if you could speak to that. Any plans for the coming year?
We don't have any specific plans for the coming year. We've had discussions with the ACO over the last couple of years, and the biggest problem for Grace Cottage is, number one, we have such a we really don't have a significant opportunity to really impact overall cost of care across the entire state of Vermont. And when you look at the cost of participation in terms of the dues that we would have to pay, as well as the potential risk that we'd be exposed to if in fact prices were to go up across the ACO, and we would have to, we would be really in a position where we wouldn't be able to afford to handle any type of a risk on that side. So we've had discussions with them about ways that we can participate, without being treated like a full service PPS hospital, but those discussions really haven't come to fruition. So really from the standpoint of cost and the standpoint of risk, given our size and given how little cash we have at any given time, we just can't justify putting our organization at that level of risk. Nor do we see any real significant benefit that the ACO could provide to Grace Cottage to offset those risks. So that's kind of where our discussions have been, and we're certainly open to further conversations with the ACO, but we really haven't been successful in coming up with a model that would make it make sense for us from the standpoint of our responsibility for keeping our organization out of a risky endeavor. So that's really kind of where we're at with that.
Thank you. I think that's what I had for staff questions. So looking to the board for any additional questions.
I'm wondering if you could speak a little bit to the Medicaid redetermination effort and how that might or might not be factored into your budget.
We did not factor anything specific in, truthfully, having zero idea how much it might affect, depending on how many people either lost their coverage or additional people got it. But we have been working very proactively. We have a very top-notch resource advocate in this facility that works closely with all of our patients, particularly with Medicaid patients, and will do anything she possibly can to help them fill all of their paperwork out. And are very hopeful that anybody that simply isn't getting their Medicaid because of not completing the paperwork, that shouldn't be an issue. Now, granted, there will certainly be some people that may lose it once they submit it because they're no longer eligible, but we did not factor any specific amount in for that, no.
Thanks. And if I'm remembering correctly, she helps folks sign up for the exchange plans, insurance
Yes,
plans.
she will
as
help
well.
them for anything exchange. She goes above and beyond, helps them sign up for fuel assistance, anything, any types of resources. But her primary job function is, yes, signing up for either the exchange or doing Medicaid paperwork. And truthfully, as Sarah just pointed out, if somebody loses their Medicaid, chances are they're probably going to be eligible for 100% reduced fee still anyway, or close. So as she pointed out, our reimbursement on Medicaid patients is so low. What we're really going to do is it won't have a huge impact on the bottom line. It'll just transfer it from a Medicaid contractual allowance. I mean, a Medicaid contractual allowance to a free care line. So just a different kind of deduction.
I had one question, and I'm not intimately familiar with the program, but have you considered the rural emergency hospital designation? And I was curious if there's any opportunity there, if that's something that would ever be pursued in the future.
I mean, we looked at it briefly when it came out. I mean, it certainly could maybe be a possibility for this facility at some point down the road, although I don't, it would mean us getting rid of our inpatient beds altogether. And at this point, there's a shortage of skilled nursing beds in the facility, which the majority of our inpatient, as you can tell, looking at any statistics, if we submit them, which we don't do that kind of level of detail in the last couple of years, but the majority of our inpatient business is swing bed. So, the one average of one, say, a acute patient we have a year could certainly maybe be taken care of somewhere else, but I'm not sure where those other 10 or 11 patients every day for skilled nursing would go. But it would also make a whole lot of other changes to the facility in that, part of what, for instance, pays for all of our diagnostic imaging equipment is the fact, and lab equipment is the fact that you need that for the inpatient services as well. So they're helping spread that cost out over those things. Whereas if you no longer had the inpatient business, you'd be trying to have all of those services available with only your primarily emergency department revenue and whatever the primary care patients needed. So it's a lot of factors that, it's not just the inpatient beds you're talking about, it's how that volume of business affects your overall organization. And then you'd still need a CEO, you'd still need a CFO, and now you're dividing that over an even smaller number of service lines and or total business, increasing that administrative expense.
May I ask
That
a quick
answer-
follow-up question
Okay.
to that, actually, Chair Foster?
Please, yeah.
I mean, we have been hearing from other hospitals about the difficulty in placement of their acute, their subacute patients to skilled nursing facilities in the state. And so I'm just wondering, given that you have, 19 bed capacity, but you're averaging 10 beds on average a day. I mean, has there been thought to increasing scale and so that you could spread some of those fixed costs and provide more skilled SNF, skilled nursing facility beds for the state?
We would actually be more than happy to take additional and keep our average daily census at 16, 17. I'll be completely honest with you, and as some of your questions certainly know about, based that you asked on all hospitals, is skilled patients, and one of the reasons they're getting hard to replace no matter where they're going is that skilled patients are getting increasingly more complex. They all have comorbidities. Long gone are the days where the majority of our swing bed patients, I mean, I can remember not that many years ago where almost every swing bed patient we had was probably somebody who had a hip or a knee replacement. They were just here getting PT or OT for a couple of weeks and they went home. Relatively simple to take care of. Now, the majority of our inpatient swing beds patients, although they may still be getting PT and OT, a lot of them are here for IV treatments or all kinds of other things. They're just here because they are sick in so many ways. But that we have to be careful to make sure they're people that we can take care of. But what's become more of an issue is not wanting to get stuck with those patients once they're done being a skilled patient and they need to go to a long-term care facility. and there are not enough long-term care facilities, meaning that patient is not going to end up going back home. They have to go to a nursing home. And then we end up with a bunch of, long-term care patients waiting to go to a nursing home where we're either not getting paid really anything for them to be here, like $100 or $200 a day, or as we actually quoted in our narrative response, we've had a couple of different ones over the last year where we've had one of those patients here for 3 months, where we were taking care of that patient for 3 months, waiting for Medicaid to process the patient's paperwork so that they would be able to be transferred to a long-term care facility. We had the beds available, but the long-term care facilities won't take them without their paperwork done. So, that's not anything we can change. But that's part of, there's a lot of patients that we don't take for that very reason, because we know that after the end of a week or 2 weeks of being a skilled patient, they're just going to be occupying one of our beds, and you get 2 or 3 of them here, and then you're no longer able to take the ones that the acute facilities are trying to get rid of for us to take care of, that we should be taking care of. So it's another drawback of both a shortage of long-term care beds in this area particularly, as well as most of the people in this area are relying on Medicaid.
So what percentage of patients do you turn away because you know that there will not be a eventual long-term care placement?
I don't know. I have an exact number. I mean, it could be, and it's also hard to tell because we don't always know. For instance, when Dartmouth wants to send a patient to a skilled facility, they send a mass thing out to all the skilled facilities that could take that patient, everybody around them versus, and even down to here, if it's somebody who's from this area, and they might get acceptance for that patient to go somewhere else before we have a chance to get back to them. The process of us accepting a patient when that happens is we get a referral from Dartmouth saying we have a patient that's going to be ready for skilled bed tomorrow, say. It gets reviewed, that medical documentation gets reviewed by our hospitalists, by our pharmacy department to make sure we've got the whatever is available for them, by our rehab department to make sure. So all 3 of those departments have to make sure that they can take care of that patient before we accept them. The other thing that's becoming a huge problem is with so many Medicare patients switching to Medicare Advantage plans and getting authorization for skilled stays from those. It sometimes takes 2-3 days or up to a week to get a authorization. And they will sometimes, we've run into a lot lately where we just had one a couple of weeks ago where the person literally lives 3 doors down from my office here in town, wanted to come from Dartmouth. The insurance company was insisting that they go to a facility nearby Dartmouth. They wanted to get 6 denials from facilities within a 30-mile radius of Dartmouth first before they would consider authorizing them to come here. I mean, why? I don't know. My presumption is they didn't want to pay the ambulance ride any further than 30 miles. I don't know. But, there's just so much of that happening lately that and that's partly why they get stuck in places like Dartmouth. It's waiting for us, even if we're going to take that patient, to get that prior authorization from the commercial insurance companies.
Thank you very much.
Are there any other board questions? Seeing none, I'll ask the healthcare advocate if they have any additional questions.
Nothing up from us. Thank you.
Seeing none, I believe I'm sorry, public questions, I think is the next. And Chair Foster, I don't know that I can see if there's any questions, so.
Oh, I don't see any at this time.
Could I just ask a quick question, which is out of a total revenue standpoint, Dave Merman, sorry, I don't think we've met before. New to the
We have
board. Nice to meet you both. But out of a total revenue standpoint, what's the breakdown of inpatient to outpatient for your organization? 20/80 or?
I can
I'm not
see.
sure if
So our gross patient revenue that we submitted in the budget's $44 million. Strictly outpatient of that is about 27 million. So our outpatient business is a little over half of the total revenue submitted. Inpatient, if you combine inpatient and swings together, is about 11 million. So about 25% of our total revenue. And then the remainder is the primary care practice, which is just under 8 million of that 44 million.
I'm sorry. So is inpatient the 11 million or the 27 million?
11.
Okay. Oh, that's in gross.
In gross, yes.
Okay. So roughly a quarter inpatient to 75% outpatient is where the breakdown is. Just more curiosity than anything.
Yep. Yes.
Great. Thank you.
Seeing no public comment or questions, I will turn it back to Chair Foster. Or I think that's correct. Or Susan, I don't know. Please correct me if that's incorrect. Still getting used to it for new process.
Yeah, no worries. Seeing no comments from the public, we like to have the hospital get one more chance to kind of leave us with your parting thoughts. And so we'd welcome to hear anything you want to leave us with today.
No, I would just say, we appreciate the opportunity to participate in this process. I think we're really proud of our performance year over year, as well as the budget we submitted for your consideration. We really believe that it accurately reflects, what we need to continue to carry out our mission of taking care of our communities and our patients. And we believe that it's prudent, it's efficient, and I think it really reflects the local needs of the healthcare of this region. And we are happy to answer any questions that come up after this morning, and hopefully you'll give our budget your fair and considerate review. Thank you very much.
And I think I might add, not that it necessarily is specific to this budget, but in Doug's initial comments, for those of you that aren't really familiar with where Grace Cottage is or how we're located in comparison with other hospitals, it is true that we're 19 miles north of Brattleboro and a little over that southwest of Springfield. But if you ever looked at a map of southeastern Vermont and where we sit on that map compared to the next closest hospitals in the north of us, we're about an hour south of Rutland, and it's an hour the other direction. So it's the people that live in the north service area in the north and west of us that are all, because the question has come up many times over the years, well, what do we need Grace Cottage for? You're only 19 miles from BMH. Well, a lot of the patients have already traveled 45 minutes or more or an hour over back mountainous roads to get here. And if we weren't here, they got to drive the other half hour to get to Brattleboro. So, it's a crucial spot in this service area to have this hospital centrally located the way it is, and with the rest of them so far away from a lot of those people. I drove an ambulance when we owned one years ago for 6 years, and let me tell you, it's a long trip to get here from some of those locations, especially in bad weather. And when you're taking a patient from here to Brattleboro in bad weather at 2 a.m.
All right, well, thank you. I think at this point, we can adjourn until our next date, which will start promptly at 10. I don't know if we need to formally adjourn, Chair, or how that part works.
Yeah, we can, I'll adjourn the meeting until 10 a.m. and then we'll be with Northwestern at 10. Mr. Brown and Mr. DeVello, thank you very much for your presentation today and for your submission.
Thank you so much.
Thank you
All right,
very
have a
much.
good-
Have a great
Have a
day.
good day. Thank you.
Bye.
Bye-bye.
Attend.
Hello?
Oh, good morning, everybody.
Good morning.
Good morning.
Morning, Peter.
Okay. Cassidy, are you here? Let's see.
I'm here and ready when you are, Chair Foster.
All right, great. So we'll resume our meeting, and next we'll be hearing from Northwestern Medical Center. And I see Mr. Wright is here with his team. So Mr. Wright, I'll have Mr. McCracken swear everybody in, and then we'll have an opening statement from you and your colleagues, and then Director Lindberg will start going through the slides to review. And I think Mr. Sutter will be leading some of the staff walkthrough of the factors and the questions. So I'll turn it to Mr. McCracken, and thank you all for being here.
Thank you, Chair Foster, and good morning. Mr. Wright, who from the Northwestern Medical Center is going to be presenting and answering questions today?
Mr. McCracken, I've got John Cassavant, who's chair of our board of directors, myself, Stephanie Bro, our chief financial officer, Devin Batchelder, who's the manager of budget and decision support. And then we also have Dr. John Menadeo, our chief medical quality officer, Dr. Dawn Craigle, our chief nurse executive, and Jonathan Billings, our chief operating officer. Those folks will be answering questions potentially anyway.
Thanks very much. I will swear you all in at the same time. So if you could all raise your right hands. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
I do.
Great, thanks very much, and I will turn it back to you.
Thank you, Mr. McCracken. Chair Foster, Sarah, let me just start by saying we really appreciate the wonderful support and collegial partnership that we've had with Sarah and her staff during the budget process. It's really been quite nice. Communication has been really strong. Chair Foster and members of the board, as well as the healthcare advocate, we greatly appreciate your the dedication of your service to the state of Vermont. I'm going to quickly hand over the opening part of our quick presentation to our board chair, Mr. John Cassavant.
Thank you, Peter. Thank you to the board, and thank you to Chairperson Foster for joining our board meeting a few months ago. I'm going to be pretty brief. I want to tell you a little bit about our board and a little bit about what we're doing, and then I'll turn it back over to Peter. I've been on the board at Northwestern Medical Center twice, starting in 2002 for the better part of the last 20 years. My dad started practicing medicine in Franklin County in 1954. The hospital provides services to me and my family, to our community. On our board is the chief of our medical staff, a retired lawyer, a retired hospital CFO, district director for the Vermont Department of Health. We're pretty deep in our knowledge, I think, and very, very committed to Northwestern Medical Center. Our administration, under the board's direction, has developed a budget this year that I think is both sustainable for our board or for our hospital and responsible to our community and to the healthcare system in Vermont. We're very aware of our place in that community in Vermont, not just in Franklin County. It's been a year of transition. We're in a new era, kind of post-pandemic and a time of endemic. And we have luckily enough to have great leadership stability, most of them around the table today, or maybe all of them around the table today. We are working hard, as I said, to be responsible to us and to the system. And in that way, this year, we've reduced our number of travelers from 53 to 32 and hope to, in the next 6 months, reduce that again significantly. That obviously affects our cost greatly. We've invested in a system to help recruit and train nurses, kind of an earn to learn program. There are 2 of them that allow our staff to move through the ranks, the nursing ranks, which we are very excited about. We're really, I have a sister, she's a retired educational administrator who started by taking care of my mom during the pandemic and is going to go off and get her RN at 62 years old. We are reestablishing connections that were interrupted during the pandemic with our partners in the community and in the greater healthcare community in Vermont. And we think we're on the right path. As I said, we've developed a very responsible budget, and we ask your support of that budget. Thank you.
Thanks, John. I appreciate that. I also want to take an opportunity to point out that Wayne Hobbs, our Chief Administrative Officer, has also joined us today, though because of his newness, won't be answering any questions. And a strategic partner, Chip Holmes from Ovation Healthcare, in which Northwestern Medical Center has had a 40-year relationship with, has also joined us today just to show his support. As John said, it's been a year of transition. It's also been a year of challenge for us. We're currently at a negative 6.5 operating margin. That is a result of shortcomings in gross revenue, massive shifts in payer mix that have had a significant impact on our net revenue. We've made some strategic investments in salaries and benefits to keep with the market, and that has actually helped drive down that traveler number. That has helped recruit and retain, which, believe it or not, even though we're making the investment and are over $2 million in salary, is actually helping keep costs down, if that doesn't sound too upside down. Our benefits are off. You know, you can't really control when your team members need to use their healthcare plan, but our benefits are a little bit over. Our supply costs are over, but that's strictly because of utilization. I want to point out that one of the things that we're the most proud of is we have about a 13.3% supply cost when compared to our revenue, and that is one of the highest in our peer groups in the Ovation and Premier network. So we're really, really proud of that. But the shift in reimbursement continues to be a concern, particularly a pretty significant upward shift in Medicare Advantage and the kind of contract terms that we have with the big Medicare Advantage provider, which if you want to talk about, we'd be happy to go into executive session later on. So that's just a quick outline of what this year has been like and what we're trying to do. As we try to climb out of that hole, we've done everything we can to be a good fiduciary by trying to climb out of that hole and get to operational stability while doing our very best to follow the budget guidance that the board has put out. So there's no doubt about it. We didn't hit where your recommendations were, but I think we did a very good job at coming very, very close. And what we're asking for could certainly be more, but we wanted to be, again, responsible to your requests and responsible to the community at the same time. And I think when we look at community need, we've only put forward what we need, and we've struck a fairly fair balance between the two requests. So I'm gonna kind of turn it over to Stephanie Bro, our Chief Financial Officer, who's going to do a quick recap about where we stand today in terms of, Northwestern Medical Center being a low-cost provider and some of the good stats around that.
Thanks, Peter, and thanks to everybody on the call today. You know, I think John and Peter have really already touched on some of the things that I wanted to touch on, right? John started by saying, we never take a budget submission lightly. We never take a rate increase request lightly. And so I really just wanted to take a moment and acknowledge the conversation that I heard at the beginning of these budget hearings, right? How do we look at affordability, but also hospital accountability, right? That's an issue that's very real and it's really complex. And so I don't pretend to have all of the answers. I don't think anybody does. And so that's why I think we have to continue to talk about it as a group. I think what's something that struck me, right, the most about that conversation is how similar it really is to the conversations that we do have internally. Our leadership team and our board, every time we prepare a budget, we kind of take a step back from that budget and we ask ourselves the same sort of questions that you ask of us, right? Did we hit the guidance? If we didn't, how come we didn't? And how close can we be to achieving the compliance with your guidance? What is the rate increase request that we have asked for? And what does that do to pricing? What does it do to our community? Is it fair? Is it appropriate? Is it really a price increase to help us cover some expenses that we truly can't control, or is it a price increase for things where maybe we should be taking more risk and be on the hook? And so I really think this budget does put a significant amount of accountability and risk on NMC, but does help us cover some things that we truly can't control. We ask ourselves, how much of an operating margin, right? What is that reinvestment margin that I like to call it? What is that? And is that enough? And is that sustainable? So really a lot of parallels. You guys are wrestling with the same things that we're wrestling with. And I really think that we're taking a step in the right direction. With Sarah's tool, I know the tool her and her team have developed. I really want to go ahead and echo some of the compliments that I know my peers have already made around that tool. It's not perfect, but we can't let perfect be the enemy of good. And it's really a step in the right direction. So I really appreciate it. I think the data will show, right, that NMC is a low-cost provider. It's something that we pay close attention to and want to continue to be. It's really important to us. NMC has worked really hard to control our expense growth, and we think we have budgeted fairly and appropriately for inflation. NMC has a long history of being below average or below the median for rate increase requests, so I think the data shows that too. Peter already mentioned and John already mentioned, some of the great progress we've made on reducing travelers. And this budget holds us accountable to continue to do that. This budget holds us accountable to continue to be a top performer around metrics like supply cost. And I really just wanted to give, really some credit to Sarah and her team for all of the analysis, all of the time, all of the work. If anyone can appreciate how much time it takes to put these budgets together, it's me and all the other hospital CFOs out there. So huge kudos and thank you for everybody's time. I'm going to turn it back over to Peter just in the interest of time. He's going to speak a little bit more about kind of our future strategic direction, and then I think we'll hand it over to Sarah.
Thanks, Stephanie. So just kind of where are we going now that we've kind of, the past is the past, we can't change. We only can control what we do today and where we go tomorrow. We're in the process of launching a strategic refresh. Come October 1 will be the beginning of the third year of a 3-year strategic plan. And we're going to be doing some planning over the next 6 months. So as we look to develop next year's budget, we have our strategic focus in line. Our strategic plan is exceptionally strong. One of the things that I was really impressed about when I interviewed and a major decision for me to come to this organization was an incredibly strong commitment from frontline staff all the way to the board to be a leapfrog grade A hospital and to be a 5-star hospital. Those are above all else how we start every meeting with those two goals in mind and how we keep our razor sharp focus day in and day out. The board is committed to being an independent hospital, but not a hospital on its own. We have incredibly strong partnerships with the University of Vermont. We obviously, with them being 22 miles down the street, we share a lot of patients that go back and forth. As my friend Jonathan Billings likes to say, we have the greatest NICU in the world. It's just 22 miles down the road. So as we deal with challenging babies, we work really hard to make those transitions in care at all levels, whether older adults or young babies, really, really smooth. And we're very proud of that UVM partnership. And I work very closely with my peer, Dr. Leffler, and with Dr. Epen to make sure that that partnership continues to strengthen. We also have an incredibly strong relationship with Dartmouth Hitchcock Health and a telemedicine program. So we have a tele-ICU program. We're looking at expanding that telemed program into other areas like psychiatric care and a variety of different places. But our friends at Dartmouth are very, very helpful day in and day out with patient care. And then one of the partnerships that's just emerging in the last 9 months is something I'm really excited about. We're calling it the Vermont Collaborative Hospital Network. And it is a collaboration of independent hospitals in Vermont who want to do a variety of different things together. So an example of that is our great partnership with Copley Hospital, how we're sharing a cardiologist. Another great example is a group of those 6 hospitals who want to lower their cost on fuel oil. Really exciting projects there. Things that we can't get through our premier GPO, like fuel oil. The cost of laundry is probably one of the single greatest cost increases that is driving our budget to be out of whack and something we literally have zero control over. So we're partnering with Ovation Healthcare, a national organization that manages and works with hospitals across the country. To figure out how we can come up with our own solution to not have to rely on outside vendors. And that's really exciting. And the collaborative network, like I said, is just getting off the ground now, but all kinds of purchasing and collaborative efforts that, again, strong partnerships. We don't necessarily need to talk about ownership, to talk about being part of a system, but what we really want to talk about is who do we work with day in and day out to provide great patient care and keep it at a low cost. We're working diligently to improve our access to specialty care. We have long wait times in some of our subspecialty areas, and we're working hard to get those wait times down. We're working now, I think, Stephanie, I'm going to look to Stephanie to check my numbers on this, but I think we are 4 days from referral to scheduling an appointment. Is that right? Yeah. So that number was way out of whack. It was several weeks, and we worked really hard to get that down. And that is, a continuous project. We're very committed to becoming a high reliable organization. Dr. Minadeo and some other folks lead our efforts to continue to provide education on what that means. So every week, we're providing education sessions. We require new employees to go through our high reliable education, and it's really quite helpful in making changes every day and improvements in safety and care. We're also very committed to lean daily management, doing Gemba rounds every day, having KPI boards in all of our key departments, and driving change and improvement on a day in and day out basis. But again, we still face all the budget risks that we've already discussed. Subacute days is something that that we've gotten questioned about, and that's one of the risks that Stephanie is talking about. We're budgeting for 1,000 day reduction in subacute days. That's a big risk. That relies on our ability to get patients out of the hospital and into a more appropriate level of care. Our payer mix and net reimbursement also continues to be a risk that we're willing to take. The increase in Medicare Advantage, just one of the items under that. And uncontrollable cost increases, like I just talked about laundry, that we're all struggling with. So we have a razor sharp focus for the future, and a good plan to attack it. And we're looking at all the partnerships to help make that come to fruition. So I'll stop there, and we look forward to answering your questions. But thank you for the time.
Thank you very much. Let me just give a quick overview of the things we're hoping to hit in your hearing today. So you've already addressed some of these in your opening statements, but just trying to understand some of these investments in some more detail, maybe get some pro tips for how you were able to reduce some of these administrative overhead costs, what you're finding to be successful in your traveler reduction efforts. I know that it certainly makes sense to me that you would need to invest to realize some of those payoffs. The increases for their non-physician salaries, already touched on some of the strategies you're using to increase your efficiency and your continued focus on quality. Just a little bit more detail about some of that variation in the cost inflation, which you talked about already, some strategies that you're using to try to manage that. And then just trying to understand a little bit more about pricing and specifically the gross versus the realized net among the commercial population and how you're kind of grappling with some of these utilization changes. All our PPS hospitals, we just want to double check if that little bit of bump in the final rate is going to be material to your budget. Talk about how you're thinking through the unwinding. Also, you address some of your wait time and visit lag issues that you're addressing. And you just hit the amount of time it took to get between a call and a referral. And just understanding some of your strategic decisions around infrastructure at your facility. So those are the ones that we hope to cover today. And I will move over to the tool and have Matt take it from here.
Great. And can you all hear me?
We can.
Excellent. All right. So if we filter on PPS hospitals, which Sarah just did, we can see Northwestern came in just above the 8.6 benchmark at 10.3%. And below that for change in operating expense at 3.5. Just wanted to note that among the PPS hospitals, this was the smallest increase in OpEx we've received, excluding, of course, Rutland, who budgeted a decrease. You'll also see a 6% increase to the charge master and a 4.5% increase to commercial. This chart. As noted, the NPR and operating expense is on the previous slide. NPR coming in above benchmark, and operating expenses didn't have an official benchmark, but below that, 8.6%. Moving to labor, you can see that there was a provider transfers we had to account for with Northwestern that kind of distorted these high-level indicators. But if we move to the labor tab, you can see the ECI benchmark. They're below that, and you can see a reduction in FTEs over time. A question on labor, which you kind of touched on in the opening remarks and in your narrative, but you mentioned several items related to labor, like investment in positions to improve patient care and outcomes, reducing reliance on travelers, reduction in some executive level positions. And you also mentioned you're launching a strategic refresh, so I'm hoping not getting the cart ahead of the horse, but just wondering if you could speak a little bit more about your kind of how you're viewing the workforce issues like holistically.
Sure. Do you want us to talk about that now?
Yeah, that'd be great.
Absolutely. A reduction in labor costs and reduction in travelers and retention. And we've had a significant drop in open positions to the point where we're pretty close to pre-pandemic levels when it looks at open positions. I can sum it up in 3 words: culture, culture, and culture. This is something that certainly predated my arrival in January, but the folks around here will tell you my mantra is us, them, money. So what that means is you take really good care of your people. You make sure that they feel safe. You make sure that they feel heard. You make sure that they feel like they have a voice and how we're providing care. Our leadership team, their job is to take care of the staff at the front line because they take care of patients. I don't take care of a single patient. Nobody comes to Northwestern Medical Center because Peter Wright is the CEO. They come because of Mr. Cassavant's sister is working on the front lines, and they know them and they listen and they take the time to walk someone down the hallway to a place they're going instead of pointing. So it's all about culture, and that is since the organization has started to focus, we've seen those open positions start to melt away. We've seen those labor costs start to come down. And we have quickly earned a reputation of a place that people want to come to work because they feel valued and they feel heard.
Great, thank you.
Can I just add to a couple of things Peter said? I think when you look at this graph in front of us and you look at our most recent data point, we're creeping our way up. But if we, look at maybe PPS hospitals or just all the hospitals in general, it's just an area that I continue to worry about, right? Yeah, there we go. We switched to all, and Northwestern's kind of down towards the bottom, I believe. Yeah, in that lower chunk. And so I think one of the things that Peter and I talk about, that we talk about with the board, that sort of keeps us up at night is, how do we keep pace? Is if we're still not at the top, not saying we need to be at the top, but, depending on budgets that get approved and decisions that get made, will we be able to, is our budget going to allow us to keep pace? And so it's something that we just have to continually monitor and keep an eye on. But in the current year, we absolutely, made investments in base wages and in base salaries that were above and beyond what we budgeted for. And we knew it, right? We took that on as, hey, we're going to make a strategic investment and a strategic decision outside of what our approved budget was, and we're going to invest, and we are starting to see a return on that investment, which is very, very nice. That's what you hope to see when you make those decisions.
Yeah, I think on that labor tab, our average cost is 116,000. And again, as Stephanie said, it took a tremendous amount of work to get there. And again, we're worried about what will happen if the market shifts again and labor goes up. Obviously, 65% of everything we spend money on is salary and benefits, as being an organization of people taking care of people. So it's something that we watch very closely. And as Stephanie said, we very much keeps us awake at night, and particularly through this process.
And were there any board questions about labor? Seeing none, were there any healthcare?
Well, Matt,
I'm sorry.
sorry, I was just slow. I think in the areas in this area slide that Sarah had pulled up earlier, I think one of the areas was related to the care management. I wonder if we could just get a little more color commentary on what's going on there.
Sure, we added FTEs in care management, and that's absolutely about managing average length of stay and avoidable days. I'll ask Stephanie to fill in with a little more detail.
No, you're right. It was, just like we decided to make investments in wages above and beyond what we budgeted, we did decide to make an investment in care management. It's 1 FTE. So for our organization, that's what we added above and beyond what we had budgeted, and we did that intentionally. I think you've heard it's been a pretty common theme for most hospitals, right? That it's been more challenging to place patients and get them into that right care setting at the right time. And so we really found that if we could add an FTE to that care management team, that, it could quickly be a return on investment if we are able to, move some patients to the appropriate care setting in a quicker way. And so we're just starting to see a little bit of a decrease in our average length of stay. And, it's early, so I don't want to make any promises, but at least it's moving in the right direction. And so it's going to be key to our strategy next year of, really reducing subacute days and avoidable days.
Yeah, we've had subacute patients that were here over 200 days. Actually, when you put 2 stays together, one patient was here over a year. And just, incredibly complicated, working with the state, working with every day. That requires effort. Every one of those over 400 days that patient was here. When you factor out the outliers, we're doing a very good job when we benchmark against the geometric length of stay. So Dr. Minadeo and I look at that information, and we're making great progress and feel that investment is certainly paying off.
Thank you. That was helpful. I'm wondering if this is related to on your submission, and I'm sorry, I'm not seeing page numbers. hold on. I think it's 1, 2, 3, 4, 5, 6, 7, 8, and page 11, which has an operating expense chart on the bottom. That might be the easiest way to find it, and across from the bond covenants Ovation healthcare chart. In your narrative, you indicate that using the benchmarking through Ovation, there are opportunities for continued efficiency, and that you've made the choice to invest in positions that place you outside of the benchmark to improve care and experience and outcomes for patients. Is that sort of alluding to some of your care management staff, or I just wanted to understand that a little bit better?
Yeah, that's a couple of different areas. I believe that care management is part of it, but it's also things like environmental services. So, if we were to fall, first of all, I think it's important to point out, we don't go for the 50th percentile like you might expect. All of our departments are benchmarked at the 75th percentile. So that's their target. And we're at 96% of that target. So I think that's really important to point out. But in areas like environmental services, we have to, and actually intentionally, make investments with added FTEs to make sure that we have a clean and a safe facility. We need to keep that infection rate down. Those are areas where we're a lot closer to the 50th percentile in terms of the benchmark. But I think it's really important to point out that we're already holding ourselves to a much higher standard. I'm going to turn to Stephanie and have her fill in with some more info.
Yeah, so care management, definitely one of them, the one FTE we talked about. Environmental services, one of them. And then for us, it's some of those, you want to disproportionately invest in those areas where you're really trying to make gains. And so human resources and organizational development, right? Building that culture that we talked about earlier on, that's an area. Having to recruit and retain so many employees over this past year and going forward. So there's 1.5 FTEs there, where we know we're not hitting the 75th, but we feel like we're doing what's right and what's appropriate. Information technology, that's an area we want to lean on our electronic record. We want to lean on information technology as much as possible when it comes to high reliability and our processes and making things more efficient. And so that's an area where we know we're outside of that 75th percentile by, again, about 1.5 FTEs. And then quality and process improvement. So much of high reliability, lean daily management, KPI boards, tracking, our goal against being 5-star and leapfrog grade A. We're really investing in that quality team to help us use that evidence-based information and be out on the floors working with those clinical teams and getting our workflows where they need to be. So those are just some examples. Those are most of the examples really of the areas that are not achieving that 75th percentile benchmark information that we have from Ovation.
Thanks very much.
May I just do a quick follow-up on that? Because I think it's really fascinating, and I really appreciate all the efforts. It sounds like multi-pronged efforts to improve efficiencies and ensure that you are delivering high-quality care with the goals of the 5-star rating and Leapfrog A. So I'm really intrigued by all of this. And I'm just wondering, with respect to some of that Ovation Healthcare benchmarking, do you do benchmarking within each department in terms of something more like visits per day per clinical FTE, in terms of throughput of patients? I know access is an important issue. It came out in the community needs health assessment as a critical area. So I'm wondering if you can speak a little bit to what you're seeing in terms of the benchmarking there, in terms of throughput of patients. And what metrics you look at. I'm just guessing something like visits per day per clinical FTE, but I don't know what you're using or how you benchmark. So I'd love to hear more about that.
Go ahead, Stephanie.
Yeah, you hit the nail on the head. So for the outpatient practices, that is what their benchmark would be, right? It's office visits per clinical FTE. For an area like our inpatient unit, it's going to be patient days, right? For an area like our laboratory, it's going to be, number of billable lab tests. And so I think one of the great things about the premier benchmarking information that we have through Ovation is that it really is tailored and it's department specific. So if we have, 45 different departments, we have 45 different benchmarks and we get them updated annually, and they're broken down into similar sized hospitals to us. And so you don't feel like you're working with, really old stagnant information that kind of doesn't even apply to you. But the short answer to your question is it depends what you are for a department, because they're all a little bit different.
And in terms of those kinds of outcomes, you're still targeting the 75th percentile.
That's
Yeah,
correct.
we are targeting, 75th for everyone. We're asking them to get 100% of the 75th percentile, and some are over and some are under. And we just talked about some of the areas that are under, but it's a pretty aggressive benchmark, but we believe that, that should be the right target. And then when they're not meeting it, we have conversations. It's a tool. It's part of the bigger picture of, well, is this an area where we know we're trying to focus and we're trying to invest, or is this an area that's kind of business as usual and really should be able to achieve that benchmark?
We look at every FTE that's trying to be filled, and we bring in that benchmark as a tool, and we have a conversation before any position is posted, just to make sure that each and every FTE that we put out there is reviewed carefully.
Thank you.
You're welcome.
I hope you don't mind me jumping in here, Matt, but this might be an interesting time to just talk about what I think a lot of hospitals are grappling with in terms of figuring out right-sizing the hospital versus what might make sense as a community practice. And I was just wondering if you could talk us through how you approach those strategic decisions and what sort of input goes into it for you.
Sure. Any services that we provide, and whether they grow or whether they shrink, is a strategic conversation. It ties directly to the community health needs assessment. It ties directly to what we see are the needs of the community, what we're hearing from. We do not own primary care, as you kind of inferred and could see from the physician transfers. So we work very closely with our strategic partners. We have primary care folks in an FQHC that's sprawled throughout the region, as well as a private practice that not only has several clinics in Franklin County, but has clinics across the state. So we're not dealing with small operations. We're dealing with larger, sophisticated operations who really have an understanding of the market from a primary care perspective. And we put a lot of weight and emphasis on their input. We also look at, if we don't do it, who else will? And what will that cost? You saw a lot of information, and we're not much for bragging, but I think on this one area, we're going to take a moment to brag. We are a very low cost provider. We're one of, and in some areas, the lowest cost provider in the state, depending upon the metric that you want to look at. And so it's very real to us that as we balance our fiduciary responsibility with keeping the organization afloat and making sure that we're here for the next 100 years, we also do that with, but if we don't do it, who will, and how much will that cost the community? So I think, it's a complex process. It's a delicate balance. The conversations are always rich and robust, but also very hard because it's just not easy anymore. I hope that answered your question.
Yeah, thank you very much.
Actually, Sarah, may I just jump in here for a quick second? Because one of my questions was about this point exactly. Was that all right?
Yep. Yeah.
Okay. We are trying to figure out, it is interesting. We hear about, as hospitals employ, independent practices, the costs actually to the patient tend to increase because of higher reimbursement rates and facility fees and all of that. And yet, it's interesting. Northwestern has chosen strategically to transition the pediatric practice and the primary care practice and addiction medicine and dermatology out, and it's listed in your narrative as a cost savings. And so I'm intrigued by the strategic decision and how also the practices are able to be sustainable outside the umbrella of Northwestern, and yet they were not sustainable umbrella of Northwestern is we're sort of watching, nationally, these consolidation of, vertical consolidation, just trying to understand the strategic decision you faced and why it's a cost savings to you not to keep these practices under the umbrella and how they're sustaining themselves outside. You could
Sure, I'll take a
little bit
first
to
stab of that, and then I'll have Stephanie fill in where I fall short. Let me just point out that the dermatology transfer, that was a desire from the provider to go into private practice. That wasn't a strategic decision on our part to move that. That was the provider saying, hey, I'd love to be private practice. Okay, no problem. I will tell you, as long as I've been doing this, there is nothing that will turn a clinic less productive and frustrate the staff more than having them become part of a hospital network. We're good at running hospitals, and when we bring on clinics, we treat them not like clinics. And this is the field. This is across the United States. We treat them like small hospital departments, and we burden them with hospital policy and hospital bureaucracy, which we have to do by regulation, and that just add costs to it. So I would tell you that while it's easier when you own a practice to drive a strategic initiative, it is certainly, in my opinion, in my experience, more cost effective when they're managed outside of the hospital system. It also drives better collaborative discussion and a more robust, broad look at the way the system works. In our organization, in our community, we have a federally qualified health center. By definition, that's like critical access hospital status for primary care. They get cost-based reimbursement for Medicare and Medicaid. And so literally what would be our worst payers in a clinic become their best payers in a clinic. There's also RHC status, rural health clinic status, that provides enhanced reimbursement in those areas. And quite frankly, it's about focus. So, the Notch, who's our FQHC, they do one thing. They just do primary care. They don't do anything else. They have an electronic medical record that supports primary care. They have an administrative staff and infrastructure that supports primary care. And so when you do one thing and you become razor focused, I believe you have the opportunity to do it better. You don't always do it better, but you have the opportunity to do it better. And that's what we've found. And certainly, I believe that's the case here in Franklin County. Our private practice, as we said, they don't just have clinics across Franklin County, but they have clinics across the state. And again, they're focused on one thing: primary care, their electronic medical record, their sharing of best practices, and keeping up on what's best for the community. They become razor focused. And so instead of everything coming under one system, you've got a lot of individual experts. And what we've seen and what I've seen in my time, a little over 22 years, is that particularly when it comes to primary care, this proves to be really, really beneficial for the patient, for the community, and for cost. So we made those strategic decisions to make that transfer. It did save us money because we were investing, right? The profitability or the P&L on those individual departments, we were subsidizing them when they were part of the system. Now we don't have to subsidize, so that's where the savings comes from. But now they're moving into an area where they don't not only not have to be subsidized, but because of the certain designations in the experience, they're actually getting better reimbursement and more operational efficiency. Stephanie, did I leave anything out?
I think I would just say, these decisions are always really individual. And so again, with primary care, adult primary care, we had the FQHC. And so why compete? Let's get together with them and have this conversation. That one can be a little bit of an easier thing. Again, Peter already explained dermatology was really just something that was we were approached about. I think pediatrics was really tough, right? I'm not going to lie. Like if there had not been a workable solution somewhere else for pediatrics, Northwestern would still have pediatrics, because we can't just abandon the community in that way, right? So I think some of these services, you look at them and you have to ask yourself if there might be another solution, and then you go have those conversations. And if you find out there is, then that's the best news possible. If you find out that there isn't, than there isn't, and you ask yourself what your responsibility is as a community hospital. And then I think in terms of the budget narrative and talking about our changes in expenses over the years, part of this truly is a math reconciliation as to what has happened with our total expenses. Well, these expenses went away, these ones went away, these ones went away, and these expenses came on board. That's a little bit different than trying to say this is the amount of operating loss that went away. So I don't know if that helps, Jessica. Some of our numbers are really just trying to help reconcile the change in expenses versus, what we gained from profitability or losses as a result of those decisions.
And if
No,
I
that's
could,
really helpful. The whole conversation has been helpful, so I
if I could
appreciate it.
if I could just add to that, Jessica, some historical context. We got into the pediatric business because the large group in our community had fallen apart, and we got into that business to stabilize pediatrics and access to pediatricians in our community. And in the same way, we got into the adult primary care medicine business because there was an access issue in Franklin County. And so those things were both seen, I think, by the board as temporary, and temporary was a few years longer maybe than we anticipated, but it was about creating and maintaining capacity for our service area.
Super helpful. I really appreciate it. Thank you.
Chair Foster, this is Tom, and Director Lindberg, if I could just take a second. No real questions, but I just wanted to compliment Peter and Stephanie and team. Peter, your description of the benefits of separation following a long period in our country of consolidation was one of the best I've heard. I'm sure we have it recorded. I want to listen to it again, but it was really excellent. And your commitment to community needs assessment that you started off with and the alignment of your practices based on that was outstanding. And your commitment to a focus on safe and reliable healthcare and your HRO journey being as important as your budget. You've talked more about your HRO journey in the beginning than you did your budget. Those were all outstanding. And I'm just really pleased to be hearing all of it. So I think you're on a great path for what it's worth, coming from one board member who's spent a lot of time thinking about high reliability and separation versus integration.
Thank you, Mr. Walsh. I appreciate your compliments.
I don't have any questions. This is a very strong submission and a strong presentation. So thanks for putting in the work. This was impressive. So thank you.
You're welcome, sir.
Yeah.
Were there any additional board questions on this topic?
I'm not sure which specific topic we are on.
Sorry, yeah,
we merged a lot together, but I guess I have one question that's related to utilization that I just wanted to ask, which, you talked a lot about the increased length of stay of patients you're trying to get to skilled nursing facilities, and had a nice analysis of that in the submission. I was just wondering if you could comment on other drivers of length of stay that you've identified other than trying to get patients to skilled nursing facilities.
It's all over the place.
Or long-term care. Yeah.
Yeah. It's all over the place. Even if it's not long-term care, sometimes it's just to home. We've had scenarios where we've, we pay for hotel rooms because somebody lives on a second floor and they're not quite ready. They don't meet acute status, and so they're no longer appropriate to be in the hospital, but they can't get into their apartment, which is on the second floor. In all honesty, there are less and more heartbreaking scenarios. This is an actual, we're at the mountain and we're not able to pick up mom, until Sunday or the weekend. There's crazy stuff like that as well. So it really does go all over. The majority is certainly access to long-term care. Some of it is patients with Alzheimer's. We're seeing a dramatic increase in patients who suffer from these type of memory diseases and become quasi-violent. Certainly mental health, as you've heard from other hospitals, access to appropriate beds, particularly if it's a pediatric patient or an adult where you have mental health on top of memory issues and complex medical issues that again don't meet hospital level care but need a lot of care coordination and follow-up. So there's a variety of different reasons. Our care manager would love to spend hours with you and lay that all out because I know she keeps track of them very carefully. But those are the major issues. Sometimes it has to do with just a simple ride. How do we get somebody home because they don't meet the criteria for an ambulance ride home, yet we are not comfortable putting them in a taxi and just saying go home. We do, to the safety and quality aspect that Mr. Walsh was talking about. It can be frustrating when someone's ready for discharge, but we're just not comfortable putting them in a taxi or some other mode of transportation if we don't feel that they're going to be safe, if we don't feel that they can get in their home, or anything that we feel would cause them to be readmitted. As much as we work on length of stay, we're even more focused on readmissions and keeping that number down and making sure that the patient truly is ready to go home. Stephanie, do you want to add anything?
I think I would just say our partnership with Dartmouth around tele-ICU and telestroke is also something that's helping us keep more patients here. And so those patients tend to be more complex. And so there's the kind of acuity piece that goes along with it. But I think, I think that our clinical teams would tell you that we keep sicker patients here now than we used to.
Thank you for that. One of the other questions I had along the way was how many tele-ICU beds are you staffing at this point, or beds that you use the tele-ICU services for?
We have 10. Oh, sorry, go ahead.
No, Stephanie, please.
We have 10 beds that are wired for that tele-ICU service, and I believe we're bringing 2 more online. So it's a combination of ICU patients and step-down patients who use those beds, and we do have Dawn and Dr. Minadeo here as well if you had more questions about that, but 10 is the answer.
And the other question I had for you on labor-related expenses was you discussed your plans to reduce traveler expenses, and I just wanted to know whether or not you had any concerns that would decrease access to care, staffed beds available, ED space available.
Yeah, I think, go ahead, Peter.
I think we're committed to keeping those beds open as long as we can afford to do so. If again, we're in a scenario now where a negative 6.5% operating margin. It's really tough to continue to invest in those travelers, but we need to do it in order to keep the beds open. Our census remains high. Today we have 34 patients on our inpatient unit and 10 more in our family birthing center. So a lot of those are in the emergency department as well. And so making sure that we are able to handle that load is critically important. So it's one of those things where it's painful, and it's the one thing we'd love to be able to change. But as long as we're committed to serving the community with the number of services that we do today, we have to keep them on board. But we also have a plan, and so there's several permanent staff members in training and orientation. So we also know 60, 90, 120 days out how that's going to chip down.
Thank you.
You're welcome.
Board Member Walsh, did I see your hand up, or was I'm mistaken? Okay, thank you.
All set. Thank you.
On utilization in your Exhibit 10, you note almost a $2 million reduction in overall commercial NPR just due to utilization, and this seemed looked almost entirely attributable to professional fees. I was just curious if you could describe what's occurring there, what's driving that.
Yeah, so some of that data is being skewed by the transfers, right? The movement out of pediatrics and adult primary care. So that's a big part of it. And then the other part of it is, we mentioned in our introduction, and again, if we need to go into more detail with this with you guys, we're happy to. But really seeing that big shift in the Medicare Advantage, and we bucket those under the commercial bucket. So all of those Medicare Advantage plans are in that commercial bucket for our budget submission for our numbers. And reimbursement's challenging in that space. And so that's really starting to have a significant impact. So those are the two things that are kind of driving that number.
Maybe.
I didn't have any more questions about utilization. If there are other staff or board questions.
Mine's just a request for a quick follow-up on with regard to the wait times, which I'm not sure falls into utilization, but I'm going to put it into utilization in terms of access. And I appreciated the information about the referral lag being 4 days. In the narrative, it mentioned that you don't document referral times. And so it sounds like now you've updated your EMR to be able to do that, to be able to calculate those referral lags. So on the one thing, so appreciated. Secondly, I'm just wondering if you might be able to submit that along with the visit lags by specialty so that we can get a sense of where the bottlenecks are. And we're trying to get that from all hospitals so we can really understand where are the access pain points across the state by specialty area. So just a quick request for a follow-up on referral and visit lags by specialty area.
Yeah, we definitely have to collect it somewhat manually. So we created different categories for ourselves to track the referral lag. And our goal is 3 days. We're averaging 4 days. And so some of them are at 1, and I think the highest one is around 10. And so we're happy to provide the work we have done to capture that data and provide it to you.
I want to say I really appreciate that, because I think a referral lags is under counted, and I'm sitting on several myself personally that are in the weeks. So not to NMC, I will say, but I think if we don't capture that information on referral lag, we don't really truly know or understand how long people are waiting to be seen. So I appreciate the efforts manually, if it may be. Hopefully you can get it into, a better way through the EMR system in the future, but really, really important. I know many people who are waiting weeks to have appointments just even scheduled. So thank you.
Mm-hmm.
Are there any other board questions on utilization? And I'll pause and ask, I apologize again, if the healthcare advocate has any questions on topics covered.
Thanks, Matt. Not so far. Our questions are more in the cost coverage category.
Great. Thank you. So jumping to pharmaceutical expenses and cost inflation, I was wondering if you could speak more to your experiences with pharmaceutical expense growth and general cost inflation. I know during the narrative you mentioned laundry being a major kind of uncontrollable driver, and other than pharmaceuticals, I was wondering if there's other kind of categories like that maybe are significant to the hospital, but like laundry, we don't immediately, or at least I don't immediately think of.
Yeah, we another benefit of our partnership with Ovation Healthcare is through our group purchasing organization. It's all tied together, and so they provide us with these really wonderful reports right around budget time every year that says, hey, here's what you can expect for inflation, and it's broken into really detailed categories. And it's even more detailed than what we can honestly fit into the budget system, but we try to not just do a blanket or just do an across the board. So we're able to see, oh, we should expect, this type of orthopedic implant to go up by 15%, and these other ones are only going to go up by 2% or by nothing. And so we do try to, get as specific as what's reasonable. All of that really both on the pharmaceutical side and on just the other supplies and other inflation side for NMC ended up averaging 5%. And so that's that's our approach every year, is to take that really detailed information, put it into our budget system as detailed as we can, but then calculate the overall and speak to that overall in our budget narrative. I think linen is one of those things where our inpatient census has been higher than what it had been historically. And so part of it is just a usage, like a poundage issue, right? You actually pay for linen by the pound. And then some of it is being driven by a cost issue. The lack of choice and providers available to have that linen service. And so to some extent, you kind of feel like you're out there at the mercy of the market because there's not a lot of choice. And I'll turn it over to Peter for any other comments on that.
Yeah, recently coming from Maine, I can tell you that the major systems in Maine, as well as New Hampshire, linen cost per pound is driving them to think about creating their own facilities, their own networks, becoming their own vendor, similar to what we're exploring in the Vermont Collaborative Hospital Network with Ovation. So it's just one of those odd things. It generally doesn't fall within the reach of a GPO. And so the price volatility is far more sensitive.
Thank you. Any board questions along the inflation or pharmaceutical expense line?
I wouldn't mind, it might not be, you just mentioned it, Mr. Wright, but the Vermont Collaborative Network, I hadn't heard of that myself and maybe I'd missed it, but when did that launch and who's participating in it?
So right now it's just formal conversations, although we did officially develop a logo for it. I can tell you that Northwestern Medical Center, Copley, and Springfield are firm participants. We're also having conversations with some other hospitals, and I hesitate to mention their name because it's not my place. But 3 other independent hospitals in the state of Vermont. So you can do the math on your own. And it's just about saying, hey, we're an independent hospital. Hey, we want to participate in things like, maybe I need half of this subspecialty of a physician and you need half. Can we recruit and share that member of the medical staff? It could be a physician, could be an advanced practice. I could certainly use to save 10 cents per gallon on my fuel oil. Laundry's killing me too. IT, how do we continue to make investments in IT, keep our systems safe and modern, but also find ways to share cost, whether through a collective data center or things like that. We're just getting the conversations off the ground. So the network hasn't formally legally come together, but it is a group that is actively talking, and actually now we're working with Ovation to jointly hire a position that would staff and drive these initiatives forward, hopefully by the fall. But we're doing things like, for example, Copley Hospital is also doing their strategic planning, kind of reorg their new strategic plan in the fall. We're going to participate in half a day of their strategic plan to figure out what we can do together. They're going to come over to our strategic planning process and spend a half a day with us and with our board. Our board chairs are talking about how we can collaborate more. Mr. Wooden and I spend lots of time on the phone, and I'm looking at a chemical that he discovered that helps clean surfaces a lot better than what we're using today, and is a bit of a revolutionary product. So we're sharing those ideas and collectively doing purchases together where it makes sense. So it's very early in the stages. I'd say it started maybe just shy of a year ago in terms of its development and people meeting and getting together and agreeing to work together. And so it's in those early kind of forming stages.
Well, thanks. It's interesting to hear about. I might try and reach out and learn more about it at some point that's appropriate, but thanks for the overview on that.
You're welcome. We'd welcome the opportunity to talk to you about it more.
Great. Cool. Thank you.
You ready for me to walk through my esoteric stuff, Matt?